Good afternoon, everybody. On behalf of the International League Against Epilepsy, I welcome you to this symposium this afternoon, where we hope to have a discussion about what we have learnt from the pandemic, the COVID-19 pandemic, with regard to epilepsy and epilepsy care. I understand there are in excess of 2,000 people registered for this symposium, which is truly wonderful, and we really welcome you all. This, of course, is a three-part learning experience. Namely, we have the initial case, which many of you will have completed, then this symposium, where we will highlight many issues, and then there will be a series of micro-learnings to follow. On that note, I hope you enjoy the afternoon and gain benefit, and I will hand over to Julie Hall, our Executive Director, who will be moderator for the afternoon.
So thank you very much for joining us today. We'll be spending 2 hours together, as Helen said, to go through some of the learnings so far from COVID-19 in regards to epilepsy. Before we begin and before I introduce our esteemed panel, I'd like to just run through a few housekeeping issues. The first thing is that this symposium will be recorded, but we will make sure that it is posted and therefore available to everybody on our website, and the link is shown on the slide there. The second is that we hope that this seminar is as interactive as possible, and so you will see at the bottom of your screen a Q&A icon where you can post questions throughout the symposium today. At the end of each session, we will then take those questions, and hopefully our panelists will be able to answer as many of them as possible. If we're not able to get through all of the questions, we will try and make sure that the micro-learnings that will be available after the symposium will cover any of the outstanding issues or questions that you have. Please make sure that you've disabled your microphone and video camera so that we can make sure that the symposium goes as smoothly as possible and everyone can hear and see what's happening. We have been able to get 2 CME credits for this symposium. So at the end of the symposium, you will get a link showing you how to access those credits if you want them. And then finally, as Helen said, this is the second of a 3-part educational offering that we're doing today, and we will have some self-paced online micro-learnings available in the future so that you can reflect on this learning and we can make sure that we're building our collective understanding of COVID-19 and epilepsy. Now with that, I'd like to move on to introduce our esteemed panel today. We're very fortunate in having 4 experts who are also part of Ilae, for them to be here to share their experiences and their knowledge with you. The first is Professor Helen Cross, and Professor Helen Cross will be acting as our chair of the faculty for the symposium today. Helen is the Prince of Wales Chair of Childhood Epilepsy and head of the Developmental Neuroscience Research and Teaching Department at UCL in London. She's also an honorary consultant in paediatric neurology at Great Ormond Street Hospital for Children. Helen's research is targeted around improving outcomes for early onset epilepsy, specifically with a focus on assessing the role of surgery and ketogenic diets. Helen has a number of leadership roles, both nationally and internationally. She's currently the treasurer of Ilae and president-elect, and she's also the chair of our COVID task force, from which a lot of learnings today have been drawn. Our second panelist today is Professor Sam Wie. Professor Wie is the Professor of Clinical Neurosciences. He is also the Associate Dean for Clinical Research and Director and Founder of the faculty-wide unit for Clinical Analytics and Research Support in the Cummings School of Medicine at the University of Calgary. Sam also has a number of leadership roles nationally and internationally, and he is currently the president of Ilae having served previously as the chair of the chair of the North American Commission and also treasurer of our Ilae. Third, we have Professor Emilio Perucco. Emilio is a professor at the University of Pavia and director of the Clinical Trials Center at the National Neurological Institute in Pavia. Emilio trains as a neurologist and also a clinical pharmacologist, and he's our current past president of the Ilae. Emilio's research activities are very much focused on clinical pharmacology related to anti-epileptic drugs and drug treatment of seizure disorders, as well as clinical trial methodology in epilepsy. And then finally, last but in no way least, is Dr. Ingmar Blucher. Ingmar is a professor and chair of the Department of Neuropathology at the University Hospital of Ergland in Nuremberg, Germany. He is the chair of our Education Council and also a member of our executive board. His scientific interests include clinical and molecular neuropathology of human epilepsy. And he was the founder of the German Neuropathological Reference Center for Epilepsy Surgery and the European Epilepsy Brain Bank, which was founded in 2006 with funding from the European Commission. So I'd like very much to welcome our four panelists today, and they will all be taking turns to share their knowledge and information around COVID and epilepsy, and all available to answer questions as we move through the seminar today. The seminar today will consist of 4 sessions. The first session will very much focus on the clinical observations that have been made so far in relation to COVID-19 and epilepsy, and also looking at some of the drug therapy issues related to COVID and epilepsy. And to begin session 1, I would like to pose a question that we know is one that is very important to patients, to parents, and to all clinicians. And that is, does epilepsy pose a significant risk factor for severe COVID disease? And perhaps we can start with Helen as a paediatrician, as I'm sure this is a question you get a lot from parents and from patients, and has raised a lot of concern. In your experience, does epilepsy pose a significant risk factor for severe COVID disease? Helen.
In short, amongst the children, it does not. I mean, and overall, it does not, as Sam will come to. With regard to children, of course, it appears from the experience that we have worldwide that they are prone to a much less severe disease overall than adults. And indeed, if we look at the studies that have been reported, for example, in China, only 0.9% of those with severe disease were between the ages of 0 and 14 in their series, and indeed from Italy, 1.5% aged 0 to 20. And indeed, there have been some other recent reports looking at children who've been admitted to hospital. A recent one, a report from 28 Italian centres, looking at those with definitive COVID-19. But only 9 had critical disease, and indeed 6 of those were under the age of 6 months. And comorbidities, which we'll come to, were those that appeared to play a part in determining whether hospitalization or indeed respiratory problems were indeed seen. Comorbidities such as neuromuscular disease, limited mobility, existing respiratory disease. And the other aspect is, of course, immunosuppression, which can be utilized in some people with epilepsy. But overall, epilepsy per se, and actually being a child specifically, does not make you more prone to severe disease.
Okay, thank you very much, Helen, for outlining that when it comes to children. Is that a similar case, Sam, when it comes to adults, from your experience?
I think very much so. We have no evidence really whatsoever to suggest that epilepsy per se poses a risk for severe COVID disease or for complications of COVID disease. I think that there are elements that we can glean from a large series of cases that have been published And there is also an element of some idiosyncratic response in which, with little explanation, some patients have very severe disease. However, I think that what is important to note, and I will show 3 slides that are, I think, representative of the current opinion and knowledge about risk factor for severe COVID. And one that is overwhelmingly the most important is age. As you can see in the slide here, to the right of 1 is an increased risk of death, severe disease, and to the left is decreased risk. And you can see clearly a gradation in age and with age and severity by decade. And no other element among risk factors is as important as increasing age. You can see that above the age of 80, the hazard ratio for mortality is extremely high. I mean, the horizontal is a logarithmic scale, which means that by the time you get to the last dot with the horizontal confidence intervals there, you're pretty close to over 20 or 50, so extremely high. It decreases with decreasing age, as you can see. For some reason, males appear to be more prone to severe disease. And then other things that follow a gradation in terms of severity, other comorbidities are overweight and obesity. So the more obese, the higher the risk of a severe or a poor outcome, particularly in this situation, death. As you can see there. And then there are other elements. I chose the ones that show a clear gradation. For example, socioeconomic status. And I think that this is a marker of poor health, but also of severity, of proneness to severity of COVID. As you can see here at the top of the slide, the more severe the deprivation, the higher the risk of severe disease and mortality. Diabetes, if it's controlled, is less of a risk, but still a risk. However, poorly controlled or unknown control is a marker of disease. And then you have the malignancies, both solid and hematological malignancies, interestingly, the recency of the malignancy appears to be the most important factor driving risk of severe disease. The more recent, the more severe the disease, or the higher the risk of severe disease. And then you have just comorbid conditions, coexisting conditions such as kidney dysfunction, and then things like respiratory disorders, liver disease, dementia, other neurological disorders, immune suppression, et cetera, et cetera. Notice, importantly, that hypertension has been touted in the literature and in news and so forth as being a risk factor. But notice that hypertension on its own does not necessarily entail more severe risk of COVID mortality or severe disease, but other complications do. So yes, indeed, as you can see, comorbidity is the issue. So therefore, we need to pay particular attention to our patients with epilepsy and comorbidities, especially those that are elderly or the younger individuals, as we see commonly in our practice, that have a number of comorbid conditions, especially cognitive impairment with pulmonary, gastrointestinal disorders or brain disorders. But yeah, this is very much in keeping with what Helen mentioned for children.
Okay, no, thank you both very much for that. So epilepsy alone, whilst of course there's still a lot more research that's needed, a lot more epidemiological studies that we need as the COVID pandemic continues, but alone does not appear to be as a significant risk factor, or certainly not as significant as the major comorbidities, Sam, that you're able to outline there. But what about someone who has epilepsy, who then becomes infected with COVID? How does the COVID infection seem to impact on their seizure control? Helen, would you like to comment on that from a pediatric point of view?
Well, it's our experience, and that talking to other centres, that we don't see per se, in particularly those with complex epilepsy, an increase in seizures over and above what they may see ordinarily with illness. Some of the syndromes, they're prone to seizures with fever, more seizures with illness. And certainly the reports that we've had where children have contracted usually a mild illness, they may have had an exacerbation, but something that their parents would expect with fever or illness in any case. So it does not appear to exacerbate seizures over and above what might be expected.
And Sam, from an adult point of view, for someone with epilepsy alone, I mean, obviously the comorbidities really do play a role, but epilepsy alone, a COVID infection, how does that seem to impact on seizure control?
Again, very similar to the comment that Helen just made. No evidence really that COVID per se, the infection per se, plays a role in exacerbating seizures, other than the general health and the accompaniments of the infection, whether it's fever or severe physiological stress. I think that other factors play a role, and we will talk about those, and the issue of stress and lifestyle will become prominent topics as we go along in the conversation and the discussion. But no, you're absolutely correct. There is no evidence that COVID itself. I mean, the caveat is, of course, if COVID is producing an encephalitis, or if COVID is producing an additional encephalopathy, or if as part of a severe COVID condition, the metabolic derangements that take place, be it hepatic or the kidney or hypoxia, those can certainly increase the risk of seizures. And then there is the whole issue of medication interactions, especially in people with comorbidities that are taking other medications. It's important to keep those in mind. But COVID itself, unless it's directly affecting the brain, which is not a common situation, we have no evidence that it would increase the severity or the frequency of seizures apart from a general illness, what a general illness would do.
Okay, so very similar children and adults then in terms of the COVID, having a COVID infection and how that might impact on seizure control. So it's quite interesting, Sam, and I'd like to pick up on the point you talked about stress and behaviour changes. Very interesting, the slide that everyone can see here, that many patients in answering a survey that Ilae did globally, and we had over 450 patients respond to that survey, but over a quarter of them and their caregivers found that they had increased seizures during COVID. Would you like to comment a little bit more on that, Sam? Because clearly it's unlikely to be a physiological thing, you're saying. It's perhaps more on the social side. Is that correct?
I think that this is a very important point because I think it is multifactorial. It is interesting when you see from a medical perspective that there is really no evidence of increase in seizure frequency. From the patient's perspective, it is an interesting view because, as you said, Julie, both patients and caregivers from a quarter to a third report an increase in seizure frequency. But I think that this is due to multiple factors that we need to keep in mind as we care for these patients. The first one, of course, is that people may have difficult access to medication. They have difficulty accessing both medications and difficulty accessing care, as you can see in the slide there. Again, from a quarter to a third of patients reported that in our survey. The access to health professionals is an important issue. And I think this varies from setting to setting. In our own experience in the Canadian healthcare system, this has been also an issue, even though to a lesser degree, but it's an important aspect. And this is something we'll discuss more today in terms of alternate ways of providing care, specifically distance care or virtual care or telemedicine. The second aspect, I think, is that there is a severe disruption in patients' lives with COVID and with the current measures that are necessary to restrict the pandemic and the spread of the virus. People are staying at home and their routine is disrupted. You know, the circadian routine and the circadian hygiene, if you wish, of in people with epilepsy is of particular importance. Disrupted sleep or sleep cycles, disrupted eating patterns, lack of exercise, exposure to different triggers or stimuli, and then also participation in increased intake of substances, whether it's alcohol or other substances, increases the risk of seizure. So this is the second aspect that is important to consider in terms of the causes of increases of seizures in patients with epilepsy. That stress is an incredibly important aspect in these patients. We know this from clinical experience, but in the survey, patient-reported problems in this particular regard are extremely important. You can see the numbers of people that responded yes all of the time or most of the time to various questions in a validated questionnaire. At least 1/3 report all of the time or most of the time being restless. And then you see for nervousness, for things being an effort, for hopelessness, worthless, and then depression. There is a very high prevalence of increased distress in people with epilepsy due to various circumstances. For example, stress related to difficulty getting access to medication, not being able to access, not being able to access their physician, the uncertainty of the whole pandemic, the isolation that it produces. If they are barely making ends meet with employment, then the difficulty in being unemployed or losing their income. And their financial situation is therefore very important. And then finally, and this is extremely important, the pandemic brings about for people in general, but especially with people with epilepsy, brings or uncovers mental health issues that could be there and are not present. So I think it's very important to keep this in mind. We should not underestimate the mental health impact of COVID, and we need to find a way to integrate this into our clinical care and to our questioning of patients and addressing their needs.
No, thank you very much, Sam. I mean, I think that was very clear, and we will later in the symposium talk a little bit more about how to overcome some of those access issues, medicine access and also consultation access. But the stress and mental health and disruption to lifestyles, I think all of us have experienced that, but the real impact on people living with epilepsy is obviously quite clear. Helen, from a pediatric point of view, are you seeing something similar as well, the impact of COVID psychosocially on your patients and their families?
Well, of course, with the lockdown that happened in many countries, there is a complete lack of routine. Children are taken out of school, they're in the family environment most of the time. Then there's the additional impact on the care, the parents, the guardians, about whether they're able to go to work, do their work remotely, and indeed what happens with their job. Essentially, there have been some surveys illustrating a similar pattern to what we've seen in adults, not least that seizures are reported by young people and caregivers to have increased during lockdown in their perception. On the left is the results of a survey undertaken in Spain of caregivers of individuals with genetic epilepsy, a mean age of 12. On the right, a survey we conducted through a charity in the UK to caregivers as young people over a 5-week period in June, so perhaps a little later in the pandemic. And you can see seizures were reported to have increased in both. And the reasons for, that there was concerns, as was reported by the Ilae survey, difficulty getting the anti-epileptic drugs during lockdown. There was more of a reluctance to go to the hospital and a concern that they would catch the infection if they did so. And also on the left, you can see reasons they felt there was an increased seizure frequency, inability to reach the neurologist, less regular therapies, avoiding seeking advice. But also what has been reported is a behavior change. And you can see that on the left from the Spanish survey, a behavioral deterioration reported in 1/3. The reasons behind this was reported by the individual caregivers as increased anxiety and depression in the caregivers themselves, living in homes with no gardens, so restricted activity, economic problems leading to stress in the families, and also another aspect was lack of access to therapies and routine, as the children were not attending school. And on the right, you can see from the survey from Young Epilepsy, both responses from young people as well as responses from caregivers. Caregivers reporting 50% to have a change in behaviour in this survey. And you can see mood change, sleep disturbance also being commented on. But also the caregivers themselves reporting an increase in stress, anxiety, and sleep difficulties, which they felt had an impact on the care of the individuals. That aside, of course, there are some that actually reported positivity from the lockdown, spending more time between the children and the family, perhaps more of a structure for some of the children who found it quite stressful to go into special school environments, and also being more in the outdoor spaces where they were able to participate of that, and therefore having a more healthy lifestyle. So it is quite mixed, but there's no doubt that the behaviour change in the children, but for whatever, the stress and concern in the caregivers is not going to be just during this period and may have a lasting effect as they then begin to grapple with maybe financial issues, employment issues as we go into the future, and uncertainty for that.
Well, thank you very much. I mean, it's quite clear that the pandemic has been quite disruptive to many people's lives. In terms of clinical practice, Helen, how has the pandemic affected your clinical practice? Obviously, in the next session, we will look at specifically telemedicine, but just more broadly, your clinical practice and trying to access children and provide the care during the pandemic. What ways have you had to approach this?
Well, certainly we've had to try and continue care and make sure that families had a continuous point of contact where they would be able to seek advice if possible. There has been concern about keeping children out of hospital where possible. So general advice may be a lower threshold to providing emergency rescue medication, ensuring that they have sustained supply of anti-seizure medicines, maybe giving more prolonged prescriptions than may be thought of usually. But also giving them advice about when they need to come to hospital. If the seizures are atypical, if they have a prolonged postictal period, they cause injury, giving clear advice with regard to that. And acknowledging that it was found over the course of the pandemic that there was a 20% reduction in A&E attendances, and therefore people were scared to go to the hospital, and it's getting the balance of making sure hospital attended where possible. But also, of course, we've had to, and we will talk about telemedicine, and perform remote care where possible, and try and make sure that our clinics continued, that our contact continued with the patients, and they had that point of contact if they required it. The other issue is making sure they knew where to go for advice, maybe with regard to mental health support and behavioural support. We actually had an ongoing study looking at remote delivery of a behaviour intervention, and that came into its own during this time. But I mean, it is a different way of working, and it was to ensure optimised care during this period with a different model in order to make sure that we didn't give a disparity of care to our patients.
And Helen, you seem to have really emphasised the fact that you need to keep contact. In fact, make an even greater effort to keep contact and make sure that parents and patients know who to contact, when to contact, and not to be afraid of coming to hospital should they need that kind of support, but really understanding when and how to do these things. Sam, turning to you, I know that you look after a lot of young adults. Were you seeing similar things with young adults?
Completely agree with Helen again. The issue with young adults are of a slightly different nature in the sense that they are being affected tremendously from a social and psychosocial perspective. The isolation and the inability to see people face to face and to gather together and to live their usual lives is really taking a toll in their lives. Many are finding that this uncertainty as to how long this is going to go on is playing another role in the level of stress. I agree fully that really the majority of my time in dealing with my patient population and young people as well is on psychosocial aspects and on inquiring about how they're doing and how they're coping and what can we put in place. Our services, our epilepsy service and our epilepsy program, the requirements for communication and for people answering phones or for people getting back to patients have increased very substantially. As we have moved on to virtual care and not having so many people in the rooms, now the rooms are empty, the hospitals are not full, but the phones are ringing constantly. The communication is really very active and we need more people helping with that. I think that this is important to remember. These elements are so important really that I strongly recommend that we use standardized questionnaire to ask about the mental health of our patients before we see them. We use, for example, a standardized brief questionnaire for depression, which is the NNDDIE. It's a 6-item questionnaire. Patients complete it online before they come in, or they can complete it on paper. And a score of 13 or higher, it has a very high sensitivity and specificity for major depressive disorder. And then the GAD-7, which is a measure of anxiety, again, 7 items, a score of higher than 10, identifies people who are very likely to have severe anxiety or prominent anxiety. And we have that information because sometimes you ask people how they're doing, say, I'm doing fine. And then you look at their questionnaire and say, you're depressed or you're extremely anxious. Well, yes, I am, and then the second part about this is acting on it. So you get these elements highlighted and then you need to act. So having the necessary supports around is extremely important. Whatever type of support you can get, whether it's counseling, whether it's psychological or psychiatric or groups or whatever, I think it's extremely important to implement that. This is not just for young people, but it is, I think, particularly important in that group because it can go undetected quite easily. And then it becomes a vicious cycle. They are doing poorly from the mental health perspective. Their adherence to medication suffers. Their lifestyle suffers. They incur in more substance use and poor sleep and so forth. So I think it's extremely important. It's also stigmatizing because in addition to having epilepsy and the stigma of epilepsy, now they also have the stigma of being isolated, not being able to have their usual relationships and so forth. So I think it's crucially important.
Well, thank you very much. I mean, I think again, the communication is an aspect that's really come out as something incredibly important, but so are the opportunities to perhaps really invest in more creative ways of ensuring that we're asking the patients the right questions before they even come for a consultation, and the opportunities that you had mentioned there. Incredibly important during COVID, likely to be something that continues to be important for many years afterwards. So one of those lessons that we can perhaps take further forward with us. But in terms of older people, Sam, because you also treat people who are considerably older, you've already mentioned the comorbidities as an issue. In terms of the change to your clinical practice when it comes to older people, what sorts of things are you noticing and things you've found useful there?
This is a very important question, Julie, and I really look forward to Emilio's comments when we come to the section of medication interactions, which is a major aspect in people with comorbidities, especially elderly people. Is interesting, whereas in a certain age group, we spend a lot of time talking about how are you feeling, how are you doing, are you isolated, do you need help, are you depressed or anxious or distressed? In older people, we spend a lot of time talking about their comorbidities. We talk about how are you doing? What are you taking? What medications? Is there any evidence of exacerbation of your condition? We're hoping that somebody else is looking after those comorbidities, but sometimes it's not the case. So we need to be very alert about this. Helen mentioned something a moment ago, and this is that patients stay home with severe conditions. They have their myocardial infarctions at home and they don't go to the hospital. They have their strokes at home. The volume of services for strokes and for cardiac conditions in our hospitals has dropped substantially. They didn't go away with COVID. They're just not coming to the doors because people are so concerned about this. And these are the extreme circumstances, of course, right? But I think that we need to be very alert about these and we need to be exploring continuously. This is a big chunk of our time with our elderly population. We need to emphasize to them that they need to seek care. Hospitals are actually, right now in our setting at least, pretty safe places. There, you know, the protective measures in place are very good, and people can come to hospital and be treated. The other aspect is that we need to be careful that we don't become nihilistic, especially with elderly people that have comorbid conditions, and then we neglect their condition because, you know, they're ill, they have multiple illnesses, and so forth. But we treat them equally with the same level of attention as anyone else. The medication interactions, as I said, are extremely important, and then paying attention to subtle changes, because elderly people may not have the same expression of severe disease as younger people do. So we need to be particularly careful. One aspect that is very important to highlight is this whole issue of people living in homes where the isolation is horrendous. They are extreme high-risk groups for severe disease, and the isolation that they are subjected to is extreme. And they're suffering tremendously, and getting medications to the patients, getting attention to the patients is sometimes difficult. So these settings of nursing homes, or elderly people habitations or whatever, are particularly important to consider and to keep in mind.
Thank you very much. I mean, you mentioned drug therapy, and I'd now like to turn to Emilio for his expertise in this area. We've had a few questions already coming in particularly around drug therapy. I'd just like to remind participants that if you have got questions, please go to the bottom of your screen. You'll see the Q&A icon there, and please be entering your questions, and then we can be grouping them and dealing with them. But until then, Emilio, in terms of drug therapy, one issue that's come up is around the interruption in medicine supplies and the need perhaps for more rescue medicines at home. Do you have some comments or some advice on that from your experience?
Well, I think first of all, it is difficult to give advice that is applicable across the world, because situations are very different. There are countries that have emerged from the crisis, and the pandemic is under kind of containment strategies, and there are others that are still in emergency situations, and the situation and the way of handling that differs, of course. But I would say, generally speaking, as you said, one of the points that is also was brought up by the survey that the Ilae did was to ensure that we minimize the risk of patients running out of medications. So to do whatever we can to ensure that patients have a supply, or say we suggested something like 3 months of medication, just to be able to face any potential shortages. The other point I would say, as part of general measurement, I saw there was a question from Georgia, whether we should change doses of drugs during the pandemics. We should not. Generally speaking, epilepsy should be managed in the same way during the pandemics as it was managed before. What we might do, perhaps, is lowering somewhat the threshold for using rescue medications. In people, for example, who have a seizure cluster, they may perhaps intervene a little earlier than they used to do to prevent the risk of the situation deteriorating. Another thing I would say, and this applies particularly in situations where healthcare is under strain, is to postpone changes in medications that could jeopardize somewhat people's health. So, for example, if we are considering a person, or we were considering a person who is seizure-free, gradual discontinuation of medication, well, perhaps we might postpone that. Again, the principle should be safety first. And then, as I think it was mentioned before, the issue of drug interactions is really the main one when it comes to drug therapy in the COVID context.
And in terms of anti-seizure medicines and any impact on the clinical course of COVID, or interactions with perhaps medicines that we have either now or into the future that might be used to treat COVID, do you have any comments on that and from your experience?
Well, first of all, unfortunately, we don't have a specific medication for COVID that has not emerged yet. So we do not have a specific drug to look at when we discuss potential interactions. Perhaps the classes of drugs that we hear mostly for management of people with COVID-19 is steroids, because of the implications of the inflammatory component in the respiratory system of these patients. And the steroids, unfortunately, are affected severely by enzyme-inducing agents. So we may expect that the need for higher doses of steroids in people who are receiving enzyme-inducing drugs. And the drug most widely used in this context after the recovery trial, I believe, is dexamethasone. And the dexamethasone can be given intravenously and orally. And because it's a drug which with a marked first pass effect, the interaction is minimized by giving the drug intravenously or parenterally in any case, compared with oral administration. So perhaps one recommendation I would give based on theoretical knowledge from clinical pharmacology is that if you need to use the dexamethasone in a severe case, because we are discussing severe cases, generally under mechanical ventilation, you should go for an intravenous dosing rather than oral. Apart from that, and Sam mentioned that, most of these people are really sick and they're receiving a variety of other medications. So if they need to start, for example, anti-seizure therapy, what we do is what we do in any case in these patients, and that generally use a drug which has a lower risk of causing or being a victim of drug interactions, and especially avoid enzyme-inducing agents in this context. This would be the general rule. But then, of course, the comorbidities also affect the choice of medication.
Oh, well, thank you very much for that. I mean, I think, yeah, we're still learning, as you say, about COVID. The drugs, apart from dexamethasone, were still many under trial. But I think your advice there will be something that I think people will appreciate very much. We've come towards the end of session 1 now, and I'm just looking to see if there are any specific questions that participants have based on the observations that our panel have shared so far with their experience about whether indeed epilepsy is a risk factor for severe COVID, whether having COVID appears physiologically to impact on epilepsy, on the issues around how we've had to change some of the clinical practice and the importance of mental health and psychosocial support, but also in the last session from Emilio, in terms of drug interactions, the use of anti-epileptic drugs during COVID, and what we can do to help support our patients moving forward. Are there any specific questions that people have for this session? It says, this is a question, in complicated cases of COVID with vascular intracerebral problems, were there any epileptic activities or that are needed in the intensive care? I think the question here is something specific around patients with severe COVID who also have epilepsy. In terms of intensive care.
I can probably take that question. Of course, the answer is if any patient has neurological complications, central nervous system complications from COVID, then yes, there is a higher risk of seizures. And we see these in people who have strokes, whether they're usually ischemic strokes, but they can also be hemorrhagic strokes. They can be venous or arterial. And if people, there's the few cases that also have, of course, cerebritis or encephalitis related to COVID itself. But the answer is generally yes, but no more than people would have if they just had a regular cerebrovascular event in the absence of COVID, and you need to treat those in that regard as well. I don't know if you have a different experience, Helen.
No, not specifically. I would agree with that. There is a further question perhaps I can put to both you and Emilio, very specific question with regard to AEDs, and it's about, you know, a female patient of childbearing age who's been diagnosed, who is with refractory epilepsy on a combination of AEDs, including valproate, and informs you she's pregnant, despite signing the risk acknowledgement form. Would a review of medications be warranted immediately, despite the, you know, in the height of a peak pandemic, than which suggesting no change in medication to try and minimize risk?
I would not do anything different from what I would do outside the COVID situation in this case. And the key point to emphasize here with respect to the risk of valproate in pregnancy is that we must optimize the dose of valproate and avoid valproate if at all possible before a woman becomes pregnant. Once pregnancy occurs, any change in medication should be done very, very cautiously, and in many cases it may not be warranted. Definitely, I would not warrant a discontinuation of valproate unless there are good reasons for that being safe in that situation. What you might consider is some reduction in dose if the history suggests that that may be a safe alternative. But the key point is we should optimize treatment before pregnancy. When pregnancy occurs, we normally are more conservative.
Absolutely agree, nothing to add in that regard.
Okay. Another question, with new onset and first seizures in a COVID patient, do we need to give maintenance anti-epileptic drugs? Sorry, go ahead, Emilio.
No, I was going to say, again, it depends. It would be the same as in any situation with an infection. If it is an acute symptomatic seizure, the question is, there is no indication for long-term maintenance treatment. If there is an indication from that we are dealing with epilepsy, then again, there may be a situation where you will start treatment after a single seizure.
I think that, yes, absolutely. I would add that, and if the people that are participating took the pre-symposium little course and went through the cases, they would notice that there was a specific question in there about, I took it. So I took the course before coming here, so to make sure that I learned enough. There was a specific question there about, do you continue medication in somebody who had a first seizure during COVID or whatever? And I think that we should treat this as a first seizure and look at the risk factors for recurrence. If it's a first seizure associated with a brain hemorrhage, well, then the risk of subsequent seizures is very high, and then we should probably treat this as a long-term maintenance therapy. If it's an acute symptomatic seizure related to, you know, metabolic derangements or whatever, then I think we should treat this as a low-risk first seizure that requires a brief period of anti-seizure medication, but not long-term continuation. I think that the risk for, in general, for acute symptomatic seizure recurrence when the insult is removed is low in general, and does not require a diagnosis of epilepsy or permanent anti-seizure medication therapy.
Okay. Then there's a question from a pediatric neurologist in Indonesia suggesting that during the pandemic, parents were afraid to bring their children to get their AEDs routinely, so they didn't bring the children and just obtain the medications, telling the pediatricians about the condition of the children. So they adjusted doses by relying on parents' verbal information. Is it fine to do so? And I would suggest this is the same as if we have a telephone call, or we are relying on parental reports all the time on what's happening. And I think in younger children, of course, that is the same as normal practice. In older children, we like to talk to them, and it may be that a one-off basis that this is okay, but we wouldn't want to do it on a prolonged basis. We would want to check up on the individual child themselves in due course. But in the case, you're weighing up risks and benefits, and, a risk of bringing a child or a family into a hospital situation might outweigh the risk of relying on verbal information about what's happening or what we should be doing with a dose of medication. And perhaps one further question, which is a bit of a theoretical question to Emilio and Sam, perhaps. There was some recent suggestion that perampanel may have therapeutic and neuroprotective effects in COVID-19 infection. So patients taking perampanel becoming worried about availability. Are you aware of anything to do about it, or what you may think about that?
I don't think they should worry about that. But that gives me an opportunity to mention that we should be very, very cautious about interpreting these reports when they come out. These are signals. Most of the time, these signals are misleading. And before jumping from there to advise a change in therapeutic practice, we should really wait a long, long time. So this would be my general comment. I would not expect many people will buy on that. I hope we start giving perampanel to everyone as prophylaxis or treatment for COVID. That would be disastrous.
I would only add, strongly echo what Emilio said. And, it is perampanel, and then the next one is going to be what? I don't know what, and then another one, and then another one, and then another one. I think that at the end of our symposium, I would like to bring up the issue of infodemic, which is an epidemic of information that spreads from person to person by various means uncontrollably, and then people don't know what to believe or not. So I think it's very important to be cautious with that and not to adopt these things rapidly. There is no evidence for that. If I may, Helen, briefly, there have been several questions about hypertension and ACE inhibitors and all of that. There's a brief from the WHO from April, May of this year, looking at the evidence for ACE inhibitors or ARB or blockers, by the way, and there's really no substantial evidence to show that it influences the results one way or another. So no, we do not recommend any particular changes. Emilio, I don't know if you have any comments.
Yeah, I would definitely reinforce that. EMA as well in Europe, the European Medicines Agency has come out with strong treatments. There should be a strong recommendation. There should be no change in the utilization of angiotensin converting enzyme inhibitors in relation to COVID. So this is another example of reports that proved, in fact, not to be, not to reflect, in fact, any risk situation.
Two other questions that I posed to you, really, which was, is there any difference in our treatment of status epilepticus with or without COVID-19?
Emilio, would you like to address that, or?
Maybe I can start and you may continue. I would be very, very short. I don't think we have any reason to modify the course of action of status epilepticus in a COVID-19 infected patient compared with any other patient. There might be a higher risk of respiratory depression, of course, with the benzodiazepine, but that would be a situation where in a hospital setting, you should be able to deal with that.
Completely agree. Completely agree, paying attention to respiratory depression, but these people are under ventilatory surveillance anyways, if not acute treatment. I would be more concerned about all the other metabolic systemic derangements that are in place as COVID exacerbates and becomes more severe, and dysfunction ensues, and therefore interaction clearance of all drugs, not just anti-seizure medications and all those things, but otherwise no difference from other scenarios.
Okay, and I think we have one final question before we move on to the next session, and that is someone has posed a child, a 10-year-old child, first partial seizure. This child is COVID positive. Should they be treated in any way differently from if the child were COVID negative? And maybe Helen, you want to to take that?
I would suggest not. You know, and the issue is, you know, why they've had a focal onset seizure, are they going to be prone to another one? I would suggest that we would manage it in the same way as we would otherwise, unless, of course, there was an acute presentation and an escalation. And yes, you would still treat it in the same way as you would a child with acute presentation of focal onset seizures. So I don't think we treat them in any other way than you would a child who was COVID negative.
Okay.
Julie, may I just make a brief comment? I saw a question there, but somebody asked, which was the other questionnaire? One was a GAD-7 and the other one is the NDDIE. That is a scale for depression specific to epilepsy. NDDIE, it's in the public domain.
And as we come to...
okay, thank you very much, and thanks for that clarification there.
Okay. I was just going to say that, you know, we will be posting some guidance on the Ilae website in the near future with these exact questionnaires listed.
We'd now like to move on to the second session. I'd like to invite Ingmar to join us on the panel. And Ingmar, you are going to go through what we can expect and what we've seen in terms of COVID and its impact on, I know, a number of very interesting slides for us. And based on a number of cases that you've seen yourself, what do you expect in terms of pathology from the studies that you've seen in your patients so far, the impact of severe COVID on the brain?
Yes, post-mortem studies of our body organs are indeed very helpful to better understand a new disease. And this conclusion dates back to almost the 19th century, let's say Rudolf Virchow, and presents probably the foundation of modern medicine. However, there are emerging publications which present an ambiguous scenario of observed lesions in COVID-19. It's not clear to me, I have to say, if the SARS coronavirus 2 directly infect brain tissue leading to neurological symptoms and fatality, or if brain infarction and bleeding, let's say the most commonly described severe neurological disease reported in patients with COVID-19, represent a secondary pathomechanism. And I am not questioning here the capability of coronavirus to infect the brain. This has been indeed shown some 30 years ago. My personal experience with victims of severe COVID-19 points to a secondary pathomechanism causing the fatality. What we have observed resembled a severe derailment of the patient's blood system, including disseminated intravascular coagulopathy, which starts in the lung and spreads to all other organs, including the brain. And what you can see here on that slide is one of these patients. He was a 77-year-old male with COVID-19 and severe acute respiratory distress syndrome, the RDS. He was finally treated with extracorporeal membrane oxygenation, the ECMO. And the brain dissection revealed this massive subcortical bleeding. Can you show the next slide? Yeah, this, you see here this massive bleeding, and this extended also into the lower, the infratentorial regions of the brain, as shown in the next slide, please. So you see here the cerebellum, and there's also bleeding. And the consequence here was that the patient died from acute brain herniation. And on the next slide, I can show you probably a very similar finding observed in a 42-year-old female patient who received also the ECMO treatment and showed the same subcortical bleeding, leading to acute brain herniation and death. In her case, the clinicians also suspected ischemic brain infarction 1 day before she died.
So thank you for that. Can you tell me, when you did further analysis, did you find any virus RNA in the brains of these patients?
That's an obvious question. And we tested for coronavirus in our patient and found the SARS coronavirus 2 RNA only in the lung tissue and not in the brain, not in the heart or the kidney.
But what other microscopic findings did you find when you further examined the brains of these patients?
We took several samples across all the brain regions and observed a common pattern across all our patients. Can I have the next slide, please? As we have seen in the macroscopic slides already, there was acute bleeding in the white matter. Next slide shows you this acute bleeding here in the white matter. And the next slide shows also many thrombotic occlusions in small vessels and capillary, which is a typical signature of disseminated intravascular coagulopathy. Can you turn on the next slide? Because people probably don't see these small microclots here. However, it is important to note that there was no lymphocytic infiltration in any of the brain region sampled. And I would expect such infiltrates if this was primarily a viral brain infection. And as discussed before, we also couldn't find any coronavirus RNA in a freshly sampled unfixed brain tissue block of this patient. May I have the next slide?
So you found microclots?
Yeah, that was seen on the next slide. But the important finding, if I can conclude here, is shown on this slide, and you can go for the next to show the arrow, highlighting that we saw in all our patients dying from COVID-19, we found these pre-existing microangiopathy. And this can be regarded as a pre-existing condition. And the next slide, that's probably impossible to see for most of our audience. There's this very tiny hemosiderin deposit showing that this is an ongoing process, an older process, and is a signature for previous microbleeding. And the last slide here is from our 42-year-old patient. The second patient I showed you is a similar finding of this microangiopathy, and there were no T-cell infiltrates around any of these blood vessels.
So you didn't find an inflammatory response or RNA in the brain. What about other tissues? Did you see any inflammatory response in the patients in other tissues?
Yes, we did. We did indeed. We see severe inflammation in the lung, and that was very much in accordance with the positive RT-PCR testing. Can I have the next slide? And the figures here are given by my colleague from the General Pathology Department at Erlangen, Arndt Hartmann. And what we can see here is a severe pneumonia with almost a complete destruction of all respiratory alveoli. And next slide, you see in the upper right, also the hyperplasia of remaining type 2 pneumocytes. At higher magnification and using immunohistochemistry, we now change a little bit the dyeing. The next slide. Now it becomes brownish. The positive signal now is brown for the immunohistochemistry against CD3 positive lymphocytes, T cells. And you see here that there's a massive lymphocytic T cell infiltration invading the lung tissue. Yeah, good. I think you can turn down the slides now. Sorry.
No, so based on everything that you've presented so far with these cases, Ingmar, what would you say was the primary cause of death in the COVID-19 positive cases that you've shown here and investigated? And what could have led to their deaths?
Well, there's no doubt that the coronavirus is a highly infectious and malicious virus. It primarily infects the respiratory tract and then moves down to the lung, causing the RDS due to severe pneumonia and loss of respirational tissue. And there's ample evidence for this, and I have shown you our own cases. There's also no doubt that all of our patients died from brain herniation due to massive subcortical bleeding. But I do not believe that this was caused by the coronavirus itself. I know there's published data saying otherwise, and I'm happy to discuss this later with our audience. My conclusion is that the brain bleeding occurred as a secondary event and was triggered by the ECMO treatment at the intensive care unit. We know that ECMO requires a high venous pressure to balance brain oxygenation, and that a pre-existing condition such as microangiopathy can induce such fatal bleeding. This conclusion is based on the typical subcortical pattern of the bleed, but we have observed also other brain fatalities before the era of COVID-19 in non-COVID-19 patients when receiving the ECMO treatment. So that's nothing really brand new to us. So I would like to also emphasize that we didn't see any cellular infiltration to a potential viral threat in the brain, which is most common in any other viral or bacterial brain infection I know of. Such typical cellular inflammation was well seen, however, in lung tissue of our COVID patients.
So finally then, where do you think this cascade of fatal events has its origin? And can you give us a potential direction on the chain of events that led to fatal cases?
Well, as I mentioned before, I hope I have mentioned it, and to my current understanding, the coronavirus attacks the respiratory system, and in particular the endothelium of our vasculature. There's a large body of knowledge about interactions of blood vessel endothelium with our immune system. And I would like to refer to this very recent Nature article published in July this year, showing an antiviral response beyond immune cells, such as in fibroblasts, endothelium, and epithelium, claiming that these cells are more than just the scaffold of organs, but also primed to launch organ-specific gene expression programs for antiviral defense. Once this cascade has started, it may also induce collateral damage, and disseminated intravascular coagulopathy with these thousands, millions of microclots is a common one, and we have witnessed in our cases. By the way, the ECMO treatment by itself is a threat to the brain, in particular in patients with a pre-existing condition, such as microangiopathy. And finally, the brain herniation occurred due to the acute subcortical bleeding and caused death in these patients.
Now, your findings obviously are based on a relatively small number of patients, but very interesting and important findings. Would you be able to make any hypothetical conclusions around the direction of any successful pharmacotherapy in the future?
That's probably too early to say, and we have Emilio with us, who's far more the expert. But it's my sincere belief that we urgently need a successful vaccination, isn't it? I mean, as we do not have yet a reliable drug therapy prevention of coronavirus infection with all the demanding measures to protect our society from spreading virus is the best chance we have at this time, because it is affecting the respiratory system. We have to wear a face mask and so forth. So once the infection has settled, however, in the lung, and patients require ICU treatment and ECMO, which does not necessarily occur in every infected patient, to make that very clear to all of our audience, right? The treatment carries the risk to unravel pre-existing pathologies that have not been known to the patient, to the family, to the doctors. And that was truly the course in our patients due to the vascular damage and microangiopathy that has not been really known to any of the physicians in the treatment chain.
Well, thank you very much for sharing all of those important findings and some very interesting slides. We have a number of, if you have questions, please do enter them into the Q&A. We have someone who is wishing to ask your comments on the following, Ingmar. They think that the virus may not have been able to be isolated from CSF in COVID cases where there was stroke or hemorrhage or infarction, mainly due to the coagulopathy that was happening rather than direct viral invasion. Do you have any thoughts on whether that could be the case or not, and an explanation for some of the things that you have seen yourself?
Well, I have to check if I really understood correctly, because the voice was a little bit so the question was that the virus cannot be isolated in CSF, right? in
Yes,
patient,
because
yeah,
in patients with stroke, hemorrhage, or infarction, mainly due to the coagulation that you're actually seeing,
So I believe
as opposed to
that would exactly fit our cases and our observation, that it's not the virus itself. We cannot prove that the virus has infected the brain and caused the disease primarily, but it's the derailment of the blood system with all the coagulopathy, with these millions of clots occurring in all the small vessels, that will do it, and do the stroke and hemorrhage and the infarction. Exactly, that is the case. And then there was a question of COVID-19 encephalitis. And that is obviously, that is also true. And we know that, I mean, we know that the coronavirus can infect brain. But it's an extremely rare situation. I know we have had this case vignette up front, that was a published case from Japan, but it is very rare. And the majority of neurological symptoms are related to the coagulopathy, the secondary mechanisms. And there's a question, I can see that on ACE2 receptor antibody staining in the brain. To the best of my knowledge, ACE2 receptor is not expressed in brain at all. So, but there might be an indication of another receptor that facilitates infection of brain and CNS tissue, that is neuropilin or so. I think that paper will come out soon. It's already published on BioRevics.
Thank you very much for that, and thank you very much for sharing those fascinating cases with us. I'd now like to move on to session 3, and I'm going to invite Helen and Sam back onto the panel. This session follows on from some of what we were talking about before, and that is how COVID has affected our clinical practice, the way in which we interact with our... And in this session, we're going to very much focus on the use of telemedicine, but also how we select diagnostic tools during COVID, during these times when it is not so straightforward to interact with our patients as we wish. So first of all, I'd like to invite Helen to describe to us a little bit, what do we mean when we talk about telemedicine? What does that cover in terms of the scope of potential tools available to us?
I think when we think about telemedicine, it's the use of technology in order to deal with our in whatever form to communicate with our patients remotely. So I think many of us think of it in the first instance as video conferencing, but actually the telephone is a form of telemedicine. We may even utilize email or text. Even WhatsApp is utilized in many places of the world, which is much more immediate. And so there is the issue about synchronous telemedicine. So that's where you may have video or telephone so that you actually are getting a real-time aspects of the care of what's going on, and video being optimal in view of the fact that you can actually see the patient and gain some impression of body language. Telephone isn't quite so useful, but has been used in many places in this time. But of course, and then there's the asynchronous, which is it's less immediate, of course, email, text, and even WhatsApp to some degree, even though that may seem immediate, it is not, you are asking repeated questions. So it really is any form, and there are many different aspects of this being utilized worldwide and has really come into the fore during this period of time.
No, thank you very much. So, I mean, there are quite a range of tools that we have. Some are much more available in some parts of the world compared to others. But Helen, could you describe in your clinical experience the best way to use the different types of telemedicine and how you've been able to optimize it in your practice?
Certainly, what we have utilized from the very beginning has been video conferencing, and the utilization of Zoom within our hospital made that facility available to us. And that has really been, as I can see, a lifesaver as far as keeping regular communication with patients. It's not that easy for everybody. Not everybody wants a video conference into their home. And certainly there may be some cultural and other issues that really some patients would prefer telephone calls. And there's also an issue about, and this is with any sort of telemedicine, if language is a barrier, then you know, translation cannot be undertaken so readily. There's also the issue how, as someone brought up earlier, in pediatrics, we want to communicate with the children as well, particularly in the teenage years. That's been variable. I have to say the teenagers have been much more up on technology than their parents. We're usually setting up the video call for them at the time that I log in. So I think I've had more communication with some of the teenagers than I would normally. They're used to it. But even so, it's been quite variable. And of course, video conferencing hasn't been so available worldwide. I think many hospitals, for example, in the States, switched to that. Other places have really tried to enhance it, but of course in resource poor countries that hasn't been quite so available. Some centres have really set it up, but others it's not been so available, and so telephone or WhatsApp has been much more utilised. And of course that, you know, when they're thinking about video conferencing, there has been, you know, there's the issue about bandwidth. Even when I'm communicating with some of my patients, they may not have the bandwidth that can sustain the video. So the video, actually you end up just talking without the video. Some areas of the world that hasn't been sustained, you know, there may be huge technical difficulties. There have been issues about reimbursement. I think that, you know, for example, in the US, reimbursement has been a big issue. It was insurance companies put that to one side for the duration of the pandemic, but now there's an issue about reimbursement. We don't have that problem with a state healthcare system in the UK. And I understand in places like Japan, where it was a major issue about what you could or couldn't do over a video conference, that's really been changed and moved forward in the light of the pandemic. So there is a lot of variability on the availability. What we have to do is utilize what works for us. I think there is also the issue about deciding on the optimal way that we want to do these, utilize it. As I said, for me, video conferencing works best, but you need to prepare for it as well. And the patients also need to be prepared about what to expect and how to log on. So, you know, it was good to have a view on how we may, what questions we might ask, what information we might want in advance of the consultation, such as utilizing the questionnaires that have already been mentioned. In children, we've utilized strength and difficulties questionnaire. It's widely available in different languages. And then also, you may want a different type of format, whether it's a new first patient visit or a follow-up visit. And I have to say, through the height of the pandemic, we did every consultation through video conferencing. So for a first consultation, it's quite difficult, particularly when you've never met the family, you've never met the individual. It's quite a difficult time, particularly if it's a first seizure. So there is an issue about moving forward about, I think, teleconferencing, telemedicine is here to stay, but how we use that in combination of our face-to-face visits is something we need to address in the future.
Well, thank you very much, Helen, for that. I mean, you mentioned quite a few of the barriers to using telemedicine, but you were also talking about the importance of preparedness, using questionnaires, as Sam had also talked about prior to a consultation, but also having, you know, well-scripted consultations so that you can cover things well during the consultation, but also making the most of this new technology that we all have to now embrace. Sam, when we were discussing this issue, particularly for older people, you were talking about some of the barriers and difficulties of using telemedicine with older people and had some ideas on preparation and things that we might be able to do. Would you like to elaborate a little on that?
For sure. I think that some of my comments are going to show the difference between dealing with a pediatric population or a computer savvy young person versus a not computer savvy group of people or people that, well, simply don't know how to use computers, cannot use computers, or have impairments or difficulties in communication. And I think that this is one of the main issues. In the adult world, many people prefer the telephone, surprisingly, because setting up for the video and the Zoom and all of that, they find it difficult to do. And people can have the consultation from anywhere they are. They're at work, they take 30 minutes for the consultation and then they go back to work as opposed to traveling. I mean, it's a tremendous bonus really for patients. Many in specific circumstances, most circumstances, I would say, they find it much more convenient and easier than a face-to-face consultation. But yes, those are the elements that are typically difficult. Patients with cognitive impairment that require somebody with them to help us with communication, with interpretation of their symptoms, their seizures, their side effects, and then communication of the treatment plan and so forth. The other one is language, in terms of language barriers. And we more than ever require that somebody be present there to translate, and that can make the teleconference quite clunky because it's translating from one to the other and so forth, and you don't have direct access to the patient to see what they have, see the medications that they're bringing in their bag or their pocket or their purse, and everything needs to be translated and so forth. So that's also very important. The other issue is video. Not everyone is happy with a video call because of cultural issues or sensitivities about that, and that's an important aspect to consider and take into account. And then the final one is we prefer as much as possible a video conference as well, as Helen mentioned. But in some circumstances, it's just not possible because of no availability of bandwidth or no availability of means to sustain a meaningful connection. I mean, even now we see sometimes the communication breaking in we're all in developed countries, etc. So it is a very important aspect. And I think that, I don't know if we're going to touch on this at some point, but I think that what we've come to realize is that the ability to communicate by whichever mean, but almost anything you do requires some sort of internet access and bandwidth, and this is going to be this needs to be a major emphasis of our efforts to ensure that people have access to this. It now is part of medical care. It is not a luxury, it is medical care. Bandwidth is part of medical care, and as you said, it's here to stay as well, right? I must say, however, that preparedness from the point of view of the physician, preparedness for the consult is much more central now to our consultation than it was before. You cannot improvise so many things, and you need to really prepare. We send questionnaires that people complete online, and I must tell you that the adherence to completing those questionnaires is extremely high. 95. They see it as part of their consult because it's now electronic. I'm talking to them electronically, and they're communicating with me through a questionnaire electronically as well. So I think it is very important to make use of those things. Like Helen has said, like I have said, we ask about side effects, quality of life, satisfaction with medication, dosages, everything, seizure frequency, and we're prepared. And we make it a very efficient communication that allows us to focus on the important aspects.
No, well, thank you. I mean, it is something that we have embraced during pandemic, the use of telemedicine, and there are many benefits, as you've said, Sam, to using it. However, as we've said, you need to be well prepared, and there's also quite a number of barriers, cultural, language, etc., that we need to ensure we're taking into account in using this. Helen, you mentioned around reimbursement and recognition from governments, from health systems. I don't know if, Sam, you want to add a little to what Helen was saying there, because obviously there were some issues early on. And if we are to continue to use telemedicine post-COVID and reap the benefits of it, these too will need to be addressed.
Very, very important, because I don't know what happens around the world, but in many systems where the physician is reimbursed by an insurance, a private insurance system or a public insurance, a public health insurance system, there may not be equal recognition of these services as really being as complex or valid or complete as a face-to-face consultation. And this is a situation we face in Canada. I know that in the States to some degree as well. And this is very important, because it is just as much time, if not more time, preparing to a teleconsultation than a face-to-face consultation. Somebody, I just saw a question, if I may, Julie. about what about complex drug changes and schedule titrations. Yes, yeah, exactly. It is difficult, you know, and it is hard to accomplish in telemedicine. We prepared sheets that we send and we fax and we show on the screen and then we send by email, etc. But then you need to have the patient's email and permission to email them, and so it is a complex thing. And I think that it is crucially important that funding bodies and health systems recognize that this should be treated just the same as a regular consultation. Somebody could argue that it's more work, and in some situations it is. So it is actually even the opposite, right? But it is something that needs to be dealt with. Recognition of reimbursements and availability and the fact that it's a valid and complete way of dealing with patients in most circumstances, not in every circumstance.
Okay, and then moving on from the actual consultation, taking history and trying to do some forms of examination over telemedicine. In terms of diagnostics, Helen, I know that you are keen on the use of video as a means of diagnosing. Would you like to explain a little bit more about that?
Sure. I mean, and in general, probably about diagnostics in general. I mean, I think, you know, one thing, what we can do through video conferencing, and maybe something we're more used to perhaps in our pediatrics and adults waiting to be shot down, is we can observe. And so if we can see the children playing in the background, we observe what they're doing, and we can get a fair amount out of the consultation from an examination point of view, from observing the child, their movement, their play, their developmental level. But of course, there are some key things we can't do. But the other issue is the nature of events, and video, of course, whether it be through smartphone or otherwise, is a way we do that, and transfer of the video for us to observe even in advance of a consultation, even in determining whether a consultation needs to take place sooner rather than later, can be extremely useful. Of course, it needs to be transferred securely. Parents, there may be different rules in different countries. Interestingly, our parents seem to be able to upload them to YouTube privately for us to observe, but that's not something we're allowed to observe through our hospital system. So we have to have another system by which we can arrange for them to upload videos, and we're working towards that. But certainly video of the events is extremely useful in order to try and determine A, whether a consultation needs to be immediate, or B, what the nature of the events really are, because actually description may not do the situation justice. But then, of course, we also come to the whole issue about investigation per se, whether it be a new presentation, whether it be ongoing. And of course, in the time of the peak of the start of the pandemic, and even as we reached the pandemic, many hospitals stopped routine investigations. Yes, staff were redeployed elsewhere, but there was a belief that we should minimize elective investigations. And there are certain situations where we would want to proceed, and we've demonstrated, I think, and I think there are certain guidelines that it is safe to do an EEG with appropriate precautions, and also perhaps MRI. Video telemetry may have stopped temporarily in some places, other places longer, but it's kept going safely. And these are extremely useful tools for us to not only diagnose, but plan management. And of course, if we put great big blocks on these investigations for periods of time, waiting lists build up, we're not giving optimal management to our patients. And even with regard to pre-surgical evaluation, again, epilepsy surgery in many areas was decided that it was elective and therefore should not proceed. But you know, people having ongoing seizures with the potential of cure, there's a risk of dying, we should continue where we possibly can. And I think many centres now have devised ways of moving forward with regard to, yes, not quite such the volume of cases coming through because of the precautions that have to take place, but to ensure that these patients continue the care that they require and continue with the investigation that they require.
No, thank you very much for that. And Sam, I don't know, from an adult point of view, if you want to add more in terms of EEG and pre-surgical workup.
Yes, thank you. I think that Helen has covered most of the aspects of this, but What I would like to emphasize is that and we need to make our community aware of this, and our healthcare providers and hospitals, administrators, and so forth. The diagnosis and treatment of epilepsy should not take a backseat during a COVID pandemic. Should not be put in the back burner because everything is elective and nothing is as important as something else in epilepsy. And therefore, diagnostic interventions, EEG, or video EEG monitoring, or intracranial EEG, or epilepsy surgery can continue to be done to various degrees as the system begins to open, but not later than the system begins to open. There's no reason to delay it more, right? In our hospital, for example, we continue to do EEG almost through the entire COVID at the peak of the pandemic. With some precautions, we do not do hyperventilation, and it becomes tricky, but I think that under adequate circumstances, even that could be done. That is a loss, I must say. I really feel we need the hyperventilation component of the EEG. I can imagine, Helen, in your patients, that is even more the case. But so far, it is not permitted. I think that we should find ways to do that. But video EEG monitoring with specific precautions, there's no reason. The hospitals are open, patients are in. They should be in also for video EEG monitoring. We're doing intracranial EEG and epilepsy surgery with very strict protocols and parameters, and with distancing, with numbers of people involved, and so forth. But it is being done. The video component that you mentioned, Helen, I think is also one aspect that we really need to emphasize. It is tremendously valuable to have a video of the events that the patients are having at home. And we need to find a way to make it secure, private, confidential, everything, but that we're able to see those. I mean, it would save a lot of work, a lot of uncertainty, and a lot of resources to bring people into the hospital just to video record the event and so forth. So I could not agree more. These things should be, I mean, the pandemic should be a watershed, I think, in the way we emphasize things and the way we treat various aspects of diagnostics that hopefully are here to stay.
Well, thank you, Sam. And I think that nicely moves us, in fact, onto session 4, which is very much looking at what is this new normal? What lessons, positive and constructive lessons, can we learn from the pandemic to be able to live with COVID over the next few years? Events, because in our interconnected global world that we live in, unfortunately, we're likely to encounter these types of events again into the future. There is a lot that we've learned from the COVID pandemic so far. There are many things that we can now incorporate into clinical practice moving further forward. So I would like to now invite all of the panelists back for the 4th session, and to ask, first of all, Ingmar, in terms of education, because you are the chair of our education council, in terms of education, what have we learned over the COVID pandemic? And what would education into the future look like in this new digital virtual world that we're existing in? So, Ingmar.
Thank you, Julie. I would like to start with a phrase I picked up in a recent publication by Lucy and Johnson in the August issue of JAMA Journal on the transformation effects on COVID-19 on medical education. And I quote more likely, so while many will remember the COVID-19 pandemic as a source of disruption, it is likely that it will also be viewed as a catalyst for the transformation of medical education that had been brewing for the past decade. And that is what I truly believe, that online teaching will become the new normal in medical education. And we need to adapt to this. The Ilae has just recently launched the Ilae Academy to make available a virtual campus and a learning platform for every healthcare professional interested in epileptology. I must say the Ilae Academy is not an immediate reaction to the pandemic, but the date of its launching on June 6th was accelerated by the lockdown and lack of access to any teaching and training facilities. However, there are also obstacles that need to be solved in this new normal and the medical education online. As an example, and we have talked about this already, the unlimited access to the internet and a large enough bandwidth is not yet available in many parts of the world. We do hope that this can be solved and that many healthcare professionals from resource-poor countries interested in epileptology will have good enough access to our Ilae Academy platform. And a second point that must be raised here is that the instructional design of online teaching programs needs adaptation and cannot be copied directly from our traditional face-to-face teaching. We must use other concepts to support the adaptive learning process in adults, and which has with as much interactive engagement as possible. And a third point I would like to raise here is that I envisage a change in medical competencies, and that is needed to faster respond to any novel threat to human health, as in the COVID pandemic, and to also realize and appreciate the dynamic nature of medical knowledge in a situation as ours today. The Academy is the virtual campus where you can find all of the Ilae structured learning programs in epileptology, and it is based on the currently published curriculum for epileptology. You see that cover page here on the left side with its different teaching levels from beginners to advanced proficiency, and its many learning objectives specified therein. So you can access the Academy online through the Ilae website and study all our offerings. And the next slide just briefly introduce all the currently available offers for the Academy, particularly the e-learning program for the beginners, the so-called level 1, with interactive patient-based e-learning courses addressing the most common epilepsies. Then we have a series of topic-oriented e-brain sessions and a brand new virtual and interactive MRI teaching program. Next year, we will extend our portfolio to the proficiency level 2, including the well-established VAREPA courses for EEG and a new one for MRI. We will also enforce a blended learning approach with all our summer schools and educational offerings at Ilae congresses. And we very much hope, of course, that the COVID-19 pandemic will come to an end next year and allows us to offer these face-to-face course programs again.
Fantastic, and thank you very much for that. Changing the topic slightly, I'd like to invite Emilio to discuss a little bit about research. In terms of the impact of COVID on research in general, different methodologies, our abilities to actually do research, what do you think we've learnt from COVID pandemic, and where would you like the new normal to go?
Well, for the sake of time, I think I would condense everything in 3 messages. And the first message is that research should not stop. All of us should advocate for research to continue. We should work towards restarting research wherever it has stopped. And setting aside the emergency situations, we are not dealing with those, but setting in the new context situation, the new normal. Research, we need research because research in epilepsy is the future for progress for people with epilepsy who need better treatments, better diagnostic tools and everything. So this is the first message. Research should continue, basic and clinical research. The second message is I would expand on what was discussed in the previous session, that the pandemic has revealed extraordinary opportunities to reach out to existing technologies, for example, to collect remotely reliable information. It cannot be applied to everything, of course, but we should capitalize on that and incorporate those opportunities that we have learned best how to exploit into research as well. And the last message is that whatever research we do, what we have learned is that we must incorporate contingency plans into whatever research we put in practice, especially clinical research. And contingency plans will depend, of course, on the specificity of the research we are discussing, depends on the context where you're working. But to make one example, if you do a clinical trial, you expect that at some point patients who do not have personal transportation will be unable to use public transport to go to hospital. I do not see why healthcare professionals should not visit them at home to collect blood samples and do other things as well. This is just one example of how a contingency plan can be set in place. So I would stay with those three messages. Continue with research, advocate for research, make sure that young people are motivated, the youngest generation are motivated to join epilepsy research, exploit the opportunities, but be sure that you have contingency plans, whatever you do.
Well, thank you very much, Emilio. You know, your message is very clear. Research needs to continue. I think Ingmar's message was very clear as well. Education needs to continue. Over to you, Sam. I know you have expressed this throughout the symposium. The clinical care, many of the diagnostics, etc., they need to continue during a pandemic. But we need to be creative and we need those contingency plans. Sam, would you like to comment more on that?
For sure. So my view of, I completely agree. I like that paper, Ingmar, by the way, that you cited from JAMA about how education is being transformed and the pandemic is a catalyst for transformation. I think that the same applies to clinical care. The pandemic has been a catalyst to explore new ways of providing care, and that will be the new normal. That will be here to stay to a large degree. Telemedicine in whatever form is going to stay and is going to hopefully get better and is going to be more accessible to people around the world. Very important for us also as an organization to advocate for good communication systems in every setting. The second aspect is that more than ever, this brought into focus the fact that we need to work on empowering patients and patients knowing about their condition and taking control of their own condition. This is now extremely important, especially if access to care is difficult, access to specialists, access to other services. Self-care is extremely important. Management of their seizures at home, knowing what medications they're taking, which is very often not the case. When you see the patient, what are you taking? Well, I don't remember. There's 3 pills and 2 pills or whatever. So this is very important, all of these aspects. And then the planning for situations where access is not possible, delivery of medications, alternate ways of delivering medications and other services is extremely important. What to do if the patient is sick or quarantined, or the family is sick or quarantined, who's going to help with that? I think that those services will have to be beefed up and thought about and systematically addressed. And we as health professionals also need to ask that in a consultation, like, do you live alone, or is somebody able to help you with those things and so forth? Mental health, we mentioned that already, and it cannot be overemphasized. It cannot take a back seat. I personally feel that this has been somewhat neglected in terms of the emphasis that it receives, that it is extremely important. And then if I could have the last slide, I think that one important issue, and the pandemic should be a catalyst for this, is the whole issue of infodemics. And this is an important concept. So it's an epidemic of information, so to speak. So if you see there on the left-hand side, an epidemic is an overabundance of information during an epidemic, spreading digitally or physically across people and systems, and making it hard for people to find trustworthy sources and of reliable guidance. And I cannot imagine a better picture of that definition than what is happening right now with the COVID situation. Some of the questions that we got from our audience are especially regarding that aspect. And the WHO has put together a possible framework for dealing with this that, as you can see, starts with evidence. And I agree very much with Emilio when he says that research should continue and research should be solid and should be robust. There's a temptation to fast track and to cut corners and all of that, but the evidence needs to continue to be the centerpiece, extremely important. And then explaining the infodemic situation in the management of the infodemic to the audience, engaging people, analyzing information flows and putting in place specific informations to manage this overabundance of information, and having trustworthy sources clearly identified that people can go to. And then having a system for management of this barrage of information during crisis. None of this is in place, in my view. Absolutely none of this. We're inundated with this, and there's no system by which we can address this barrage of information and the confusion that it creates. It is really counterproductive. It can be dangerous, and I think that the way forward, it will also be a specific, clear system to manage the infodemic that any crisis brings about, and the pandemic is a good example of that.
Well, thank you very much. And I think the information management, the communications, these have been issues that have run throughout our symposium today. The importance of investing in that to be able to support patients, their families, but also us as colleagues working within health services. And on that point, Helen, you throughout the COVID have not just been doing patient care, also trying to keep your research going, your teaching practice as well. But like many, many colleagues in the health service, you've also had to be involved in the rapid restructuring of services, the refocusing of health services to cope with the pandemic. What lessons do you think there are for policymakers and for health managers moving further forward? And things that you have learned from your experience that really, if we're to do this again another time, what would we do differently?
I think we all have to remember that chronic disease, and of course of which epilepsy is one, doesn't go away. It's still there during the height of an acute illness such as COVID-19. And the problem was when it took such a surge on the health services at the start in every country, then of course everything else got put to one side. Investigations went, consultations were limited, staff were redeployed. And the issue was to how to keep that going throughout. And I think one lesson is that we can't just stop treating when one illness takes over like this. We need to have a provision of care that can keep that situation going. And that's what we've learned through the telemedicine, but actually there are other aspects to it as well, such as investigation. But we also have to remember that there will also be a knock-on effect, I'm sure. Not only if there is in resource-rich countries with waiting lists, particularly with state healthcare, and how we're going to catch up on that. But when we look at some of the resource-poor countries where there are health prevention programs, vaccination programs that may well be put to one side because now of lack of resource, we really need to bear in mind what that will have implications for the future, not least for the epilepsies. And therefore, we really have to advocate for continuing care, albeit it may need to be restructured to some degree and more limited, but to deliver the care that we need to maintain the service for our patients. We also have to bear in mind that as we move forward, not only do we have to think about the mental health issues in our patients, in the children, their families, but also the care workers that have been on the front line may be redeployed and come back. This is an exhausting time, and even for those who aren't even working in the hospital, maybe more remotely, it is not the normal model of care. It is not what we normally do. Many may be working in isolation, and that moving forward may also have an impact, and we all have to consider that as we move forward. So I think overall, healthcare providers, healthcare provision has to be there, yes, for the chronic disease such as epilepsy, the health prevention in the future, that has to be maintained, and also with regard to the healthcare workers.
No, thank you very much. We have just a couple of minutes left before the symposium is due to close. I would just like to ask any of the panelists if you have any final comments that you would like to make. We've had well over 500 people attend the symposium today. Many more have done the case study before the symposium, and we will make sure that the micro-learnings and the recordings from the symposium will be available to all to view as we move further forward. But Sam, perhaps turning to you, any final comments that you would like to make to colleagues listening in to this symposium today?
Thank you, Julie. Well, first of all, of course, be careful, take care. This is not over. Ingmar said it very, very eloquently as well. Be careful yourself and those around you. Important to emphasize this to the people around us. You know, things are not over yet. We need to continue to exercise caution. Number one. Number two, we depend on our healthcare systems and the regulations they put in place. However, with appropriate measures, virtually all of epilepsy care can be delivered throughout the pandemic and the crisis. And I encourage everyone to advocate for that. It's extremely important. Somebody asked, is epilepsy surgery possible? The answer is yes, of course, it is possible. I mean, if your hospital is closed and shut down, it's not possible, but to the measure that it begins to open, there's no reason why it should be relegated there's no reason why it should be seen as a particularly risky or difficult situation for the COVID pandemic. So advocate for continued care and complete care for patients, and be prepared to adapt to the new normal. I don't think there's any doubt that this will change the way we view our practice, we view communication, and the value we put on very specific aspects of the modes of care that we provide. You know, just a word of courage for everyone to continue helping patients with epilepsy. We're all in this together.
Thank you, Sam. Thank you. Now, Emilio, any final comments from you for the colleagues listening in?
Well, I think I would close with the words that Sam has said, because I think there was no better way to say the way we should go forward. With caution, but we should go forward and start again the best that we can in all areas: education, research, and most important of all, clinical care. I think those are the priorities for all of us.
Thank you very much, Emilio. And Ingmar, final comments for our colleagues?
Oh yeah, I would like to thank you also for giving me the opportunity to mention the Ilae Academy. And there is a question from the audience whether the Academy is open to occupational therapists, physiotherapists, and speech and language therapists. And the answer is yes. I invite everybody who is interested in epileptology to visit the new website. You can come over by the Ilae website to the Ilae Academy website, and we have tons of info material there and tutorials and stuff you can review and see whether it's suited. At this moment, as I said, it's for level 1, so for beginners, and we're working on this and keep going. And we will have, I think from Thursday on, we will have a COVID-19 case-based e-learning module online for everybody enrolled in the courses.
Super, thank you very much, Ingmar. And Helen, as the chair of the faculty today, closing remarks from you?
Yes, I'd like to thank all the panelists and for everybody for listening, the very fruitful questions that we've had. I think what we have to remember as professionals involved in the care of those with epilepsy is centered to everything we do are our patients, and care does not stop. And therefore our major learning in moving forward is that care should not stop, whether it be the care or the research. We need to move forward regardless of what's happening. Okay. What someone has also mentioned in the chat has been the role of local epilepsy organisations, and there's no doubt they have an ongoing role. I think the situation will become tough because of funding. I know that from experience, but yes, we can all work in partnership to ensure the appropriate care in the future, as well as the research and improving our outcomes for our patients with epilepsy.
Well, thank you very much. And with that, I'd like to thank all 4 of our panelists today for sharing their experiences and their expertise. And I'd just like to close with some of the remarks that have been made, but the most important one, obviously, take good care. We've got a long way to go, but we're in this together. And to be able to continue to provide the care, we can do it. but it requires creativity and it requires continued advocacy. And with that, I would like to thank everyone very much for participating in the symposium today. Enjoy the micro-learnings when they're released in about a month's time. We will be sending a link so that you can claim your CME points. That will follow fairly shortly after the symposium today. And thank you all and the team behind the scenes for putting together this very successful symposium. Thank you.